Dear professors, dear colleagues, today I'm going to talk about the language phenomena in schizophrenia research. I would like to say that I'm both glad and curious to discover this important and complicated topic together with you. Here I represent the Samara State Medical University, in particular the Department of Psychiatry and the International Center for Education and Research in Neuropsychiatry. Among other data, today I'm going to mention the research project related to bilingualism and schizophrenia, which has been supervised by the Ben-Gurion University of the Negev and Bar-Ilan University in Israel. And in the second part of my lecture, I'm going to focus in details on the data of the project about action fluency deficits in schizophrenia, the project which has been guided by the Center for Clinical Research in Neuropsychiatry of the University of Western Australia. So these are the key questions I'm going to follow across my talk. The first one, I would like to refresh some ideas and facts about what kind of the disorder schizophrenia really is. Then I'm going to move to the point why we do need to pay attention on the language impairments, or so-called the third language and communication disorder in schizophrenia. And finally, I'm going to focus on the decline in action-related language and action fluency deficit and what it can tell us about schizophrenia as a disorder in general. So what is schizophrenia? Indeed, schizophrenia is one of the most extreme states that human beings can inhabit, as Spencer wrote. ICD defines schizophrenia as a fundamental disturbance of personality involving its most basic functions, which give the normal person a feeling of individuality, uniqueness, and the self-direction. From our point of view, of course, when we're talking about schizophrenia, we mean schizophrenia spectrum. So schizophrenia is different. I would like to quote here the quote from the historical retrospective, and as it presented in the lecture of Professor Assoc, schizophrenia is not a disease in the strict sense, but appears to be a group of diseases. Therefore, we should speak about schizophrenia in the plural. As Professor Assoc says, schizophrenia is not an etiological monolith, but rather an assembly of syndromes structured into relatively distinct subtypes of this complicated disorder. Indeed, when we're talking about schizophrenia, we should speak about subtypes and endophenotypes, and in particular, cognitive endophenotypes, where language plays its crucial role. Obviously, the course of schizophrenia disorder is not inevitably associated with a deterioration. More than 60% of patients had multiple episodes with either complete or partial good quality remissions, while only 30% experience continuous disabling illness. Yes, it's true, but, and however, the findings related to social support, quality of life of our patients, daily living and community functioning cause really serious concern. Just look at these numbers. More than 80% of patients are unemployed. More than 60% of patients report difficulty in socializing outside their home, and around 30% are living alone. So have difficulties in difficulties in dialogue and communication with society, and these disturbances in social communication. And moreover, regarding this social concern and these difficulties in communication which our patients with schizophrenia experience, yes, there are around 30% who live alone, but this number is very indicative. Around half of the patients, around 50%, 5% of schizophrenia patients experience the subjective feeling of loneliness. The study, supervised by Professor Assoc and Professor Vera Morgan and Joanna Bedkirk, demonstrated that this feeling of loneliness is associated with a disordered thought and cognitive dysfunction. It means that communication disturbances are related to the key features of schizophrenia, key symptoms of schizophrenia. And it means that communication disturbances also play the very important role for our patients. I would like also to mention here the definition given by Henry A. Henry A. defines schizophrenia as a chronic psychosis which is characterized by a process of mental breakdown. So patients have this mental breakdown inside, and this mental breakdown is characterized by the manifestation of a deep tendency to stop constructing one's own world in communication with the other and getting lost in autistic thought afterwards. So Henry A. emphasized the role of these disturbances of communication, which arise from the primary mental breakdown phenomenon. Another paper I would like you to pay attention at, the paper which has been published by Helen Stephenson and supervised by Professor Joseph Parnas, who is very famous for his works in clinical psychopathology. They describe the disorder of self as a primary disorder in schizophrenia. And they point to this message from the patient who is losing contact with himself or herself. Patient says, I'm losing contact with myself. And by losing contact with myself, as Professor Joseph Parnas says, patients are losing communication with others. There are many different phenomena which are described in relation to this self-disorder. And all these phenomena are experienced by our patients, such as self-monitoring or over-monitoring, self-alienation, self-defragmentation or self-disintegration, self-duplication, self-doubling, self-reflection. Our patients suffer from this inner alternation, from this inner breakdown, from this inner disintegration, which is also almost impossible to verbalize. I would like you to read these words said by a schizophrenia patient, the words which show us this difficulty to verbalize what they experience regarding their language disturbances, regarding their communication difficulties, and regarding thought processes. In these words, you really can see everything, how this self-disorder and this primary disintegration gives the ground for organization or creation of the symptoms of thought disorder, auditory verbal hallucinations, and even passivity phenomena. Patient says, when I'm with others, there are two I's, self-deprecation. The I who is among them and the I who objectively looks at this I, self-defragmentation. No matter how much I am absorbed in something, there is always an I that looks on from the outside dispassionately. This latter, outer self, is always managing and controlling me. Passivity phenomena. Even when I talk with others, the outer self listens to their words and tells them to the inner self. After listening to this, the inner self starts to talk. What is this? Perhaps it's the formation of auditory verbal hallucinations. Perhaps it's the process how inner speech transforms into the voices, the auditory verbal hallucinations, and primarily starts from this breakdown, from this phenomenon of losing contact with himself, inside himself. Our patient says the inner self speaks what the outer self commands it to do. So we can see everything here, all these positive psychotic symptoms and symptoms of disintegration domain. Here I also usually present this slide with the paper published by Parisius in Schizophrenia Bulletin, which is titled The Negative Symptoms and Emotions in Schizophrenia. And here is the poem with the words of patients, which are very indicative and again shows us, this poem shows us that patients are aware of their difficulties with communication and their problems with speech and language production, and their problems with the process of thinking when they are lost in the thought process and they experience the symptom, for example, the blocking of thought. Here they are, these words: stuck in my thinking, brain paralyzed between fear and love, stuck on you, stuck between the last word and the next, stuck by confusion, the inability to proceed any further in understanding or speech. Oh, well, I'm just stuck again. So this is what our patients experience: stuck in speech production, stuck in understanding, stuck in thought processes, despite they can be very intelligent and can have a very good education, and they might have a high IQ, but they experience these problems with speech and thought processes, which really affect the quality of life of our patients, and which really affect their ability social adjustment. Here in my talk, there is the key point message about the role of language and the paradigm which we follow in our research projects which are related to language dysfunction in schizophrenia are guided by the psycholinguistic approach. And what we would like you to remember from this talk, that it's equally important to pay attention and listen to what patient speaks about and to how it is spoken, not only to the content, but also which words patient use to describe their idea, which syntax, which sentences, which statements the patient use to formulate their thought. And linguists, they are very sensitive to hear everything, both semantics and content of speech and the structure of language, how it's spoken. Another one of our collaborative projects, or another project which we have been involved in, luckily, together with the Israeli group, also pointed to the key role of language processes in schizophrenia. This project was managed by Professors Chaim Bellmaker and Yuli Bersutsky as principal investigators, and managed by Professor Vladimir Lerner as well. And what is also very important, we have this collaboration with the team of linguists from the Department of English of the Barlan University, Professor Jonathan Fine, who has unfortunately passed away, and Professor Joel Walters. So we have had this team of linguists and psychiatrists who have been looking precisely on what was happening in bilingual immigrants with schizophrenia. And what we found, we published our data in the Journal of Neuropsychiatry. We demonstrated that patients are, first of all, they are able to acquire second language before and after manifestation of schizophrenia. But the most important, we proved that the second language can play a role or serve as a compensatory resource for maintaining verbal fluency in schizophrenia. And it's a very important finding because we know that cognitive endophenotypes of schizophrenia, those who are cognitively impaired and those who are cognitively preserved, they differ on the variable or on this feature of verbal fluency. So those who are cognitively impaired, they have significantly more prominent deficit in verbal fluency. And the fact that the second language can compensate it really gives the resource for rethinking of cognitive interventions and social rehabilitation measures for our patients, which can really which can really improve the social adjustment of our patients. And there is also a book chapter, which has been published in the Handbook of the Neuroscience of Multilingualism in Canada and edited by Prof. John Schweiter. We published a chapter on schizophrenia and bilingualism, again with this talented group of linguists from Israel. And in this chapter, we described how bilingualism can affect the course of schizophrenia, and how schizophrenia is represented in bilingual brain, some neurobiological features. And we also have been focused on the weak points and resources of being bilingual when a patient suffers from schizophrenia. Here I would like you also to remind some issues on neurobiology of language, and it's very important and related to the studies of schizophrenia and bilingualism, because we can see that schizophrenia is so-called left brain disorder, and the language is also has a representation in the left brain. reminding you these issues of neurobiology, I would like to say that this process of identifying the parts of the brain that are involved in language began a long time ago in 1861 when Paul Broca, a French neurosurgeon, examined the brain of a recently deceased patient who had an unusual disorder. Though he had been able to understand spoken language and didn't have any motor impairments of the mouth or tongue that might have affected his ability to speak, he could neither speak a complete sentence nor express his thoughts in writing. The only articulate sound he could make was the syllable tan, which had come to be used as his name. And when Broca upside Tan's brain, he found a sizable lesion in the left inferior frontal cortex, and subsequently Broca studied 8 other patients, all of whom had similar language deficits along with the lesions and the left frontal hemisphere. And this led him to make his famous statement that we speak with the left hemisphere, and to identify for the first time the existence of a language center in the posterior portion of the frontal lobe of this hemisphere, now known as Broca's area, very famous cortical zone representation of language. And this was in fact the first area of the brain to be associated with a specific function, in this case language. And we all know that Broca's area helps in producing coherent speech. And if we remember schizophrenia patients, we remember that one of the key symptoms which has been represented among criteria of key criteria of schizophrenia in the statistical classifications of mental disorder was incoherent speech. So we again emphasized the role of language through these secondary findings on language representation and neurobiology of schizophrenia. And also the second area, I would like to again mention the Wernicke's area, which helps speech processing and understanding language. Karl Wernicke, a German neurologist, discovered this another part of our brain, which is involved in understanding language, and it's located in the posterior portion of the left temporal lobe. And it's well known that people who had a lesion in this location could speak, but their speech was often incoherent and made no sense. And Wernicke's observations have been confirmed many times since, and neurosciences now agree that running around the lateral sulcus, also known as the fissure of Sylvius, in the left hemisphere of the brain, there is a sort of neural loop that is involved both in understanding and in producing spoken language. And at the frontal end of this loop lies Broca's area, which is usually associated with the production of language or language outputs. And at the other end, more specifically, in the superior posterior temporal lobe lies Wernicke's area, which is associated with the processing of words that we hear being spoken, or language inputs, so-called language inputs. Broca's area and Wernicke's area are connected by a large bundle of nerve fibers called the arcuate fasciculus. So here are where the words are presented in the brain. So occipital lobe, even this vision area in cortex is responsible for reading words, for how we see the words printed on the paper. And motor cortex is related for word production, saying words. Wernicke's area, once again, it's about hearing words and language comprehension. And Broca's area is responsible for language production and also thinking about words, formulating our thoughts. So here at the slide, you can see what we have been just discussing. A very simple, or I would say even simplified scheme about how the Broca's area, the Wernicke's area, and the motor cortex are interrelated, interconnected, and interact for supporting the processes of language understanding, language comprehension, and the speech production. And one more simple scheme I would like to show you to emphasize the role of left brain in supporting the processes of language and speech production and comprehension and language processes in general, in thinking and understanding the context of social communication and in learning behavioral patterns. And you can see that in the left brain, the frontal areas are responsible for explanation and decision, and also for mirroring others' behavior, so learning behavioral patterns. And it's very important because, for example, action language is related to actions and behavioral patterns, and thought processes, and for example, the speed processes. The more you act, the more you interact, the more vivid and fast decision making or thought processes you can have, you can develop. So language, actions, and social interactions are related to cognition, and not only social cognition, but cognitive abilities in general. And of course, you can see here other zones of responsibility for verbal reasonings, for understanding and production of words of the self and others, so attending to social feedback, for inferring by the context, and all these processes are associated with the left brain, and predominantly with the frontal and temporal or temporoparietal cortex. So coming back to the linguistic terms, we can say that the grammar and syntax are based on the Broca's area, and acquisition of phonetic semantic components are related to the Wernicke's area. Lexical and semantic processing are associated with the activation in temporal and temporoparietal regions, including the middle temporal lobe. And why I show this, because we will talk about this when we will be talking about the damages and disturbances of brain functioning in relation to schizophrenia disorder. So you can also see here a very important zone, the anterior prefrontal cortex, and we should remember it as well, because retrieval of lexical and semantic data leads to the activation of this particular zone, this particular area, cortical area. And it's very important because this area also suffers in schizophrenia. And it is very important also to pay attention on frontal cortex and basal ganglia in general, because a mental grammar, which involves procedural memory, also rooted in these particular areas and brain regions. And one more issue is related to verbal fluency and its association with the brain regions. It's normally associated with the left inferior frontal gyrus. And why I do pay attention again on verbal fluency and its neurological underpinning as the process, because verbal fluency deficit is one of the key feature of the cognitive endophenotypes in schizophrenia. I would also like to say a few words about the difference in bilingual and monolingual brain, and it's very interesting and important and associated with the data I presented to you regarding our research on bilingualism and schizophrenia. It is interesting that the weaker second language, especially when it has been acquired later in life, not since early childhood. This weaker second language is processed through brain mechanisms differ from those underlying native language processing. And for example, that same Broca's area, which we discussed, is the language organ only for native languages. So not only this left brain area for right-handed speakers, but also it's important to say that it works for native languages, whereas the remaining part of the left inferior frontal gyrus, again, might be responsible for second language. And anterior parts of the left prefrontal cortex, as well as the anterior cingulated cortex, are involved in the second language processing. The research by Abu Talebi and colleagues demonstrated this. Another fact is related to the left hemisphere brain regions, and I would like to emphasize this again because the schizophrenia is also named as the left brain dysfunction or left brain disorder. And here we can see that in native right-handed speakers, the discourse, building up the context of communication, for example, the lexicosemantic store and pragmatic deficits in generating inferences, producing main concepts, ideas, formulating thoughts, or central themes, and the reduced sensitivity to the communicative context depend on non-dominant right hemisphere dysfunction, native right-handed speakers. So we can see here that in native language, not only language zones in the left hemisphere, but also non-dominant right hemisphere is responsible for complicated language processes. Another important finding of the PET study which was managed by Klein and the group, they demonstrated that the cerebral blood flow has been significantly increased only in the left putamen when processing in the second language in comparison to the first language. And again, we can see that in native speakers, and if we're talking in native language with the patient, we can understand that both hemispheres and many different neural networks are responsible for this native language processing. While when we're looking in second language, these language cortical responsibilities are lateralized to the left brain. And finally, the brain impairment in schizophrenia is represented in the frontal cortex and other areas in the left hemisphere. So many researchers follow this hypothesis that schizophrenia is the left brain disorder. So research groups found the specific deficits in left hemisphere, the impaired left dorsolateral prefrontal cortex in schizophrenia. They also find positive correlations between metabolic change in the left frontal and the left temporal parietal language areas and the severity of formal thought disorder, as well as vulnerable left posterior superior temporal gyrus and left angular genres in schizophrenia. So we can see which areas are vulnerable, and what is interesting, the areas which are responsible for language are impaired in schizophrenia. Other data also show us the decreased left hemispheric gray matter volumes, lower left frontal activations in patients with schizophrenia, and also progression in the temporal lobe changes across the course of schizophrenia. So we can see here that these neural correlates of schizophrenia are summarized in the direction of the failure of hemispheric dominance for language concept. And these are the research projects by Greeley and Timothy Crow and Sommer and Knotchel and Fornita and many other researchers who proved and supported this particular hypothesis. It is also important to say that this neurobiological representation of cognitive deviations are related to left hemisphere and prefrontal cortex. And we should also remember this area, dorsolateral prefrontal cortex, and its dysfunction as associated with the distorted connectivity, the declined interactions with the brain regions of the parietal cortex, the thalamus and striatum, and also impaired inputs of dopamine, GABA, and glutamate neurotransmitters. So there are enough proofs that show us that those areas which are responsible for language are also related to those areas which are damaged and or disturbs in terms of function in schizophrenia. And finally, I moved to our research project. We published our data in the journal Psychiatry Research. This project was supervised by Professor Assoc and Professor Joanna Badcock. And in our research, we demonstrate for the first time that there is a selective action verb fluency deficit as compared to mental verb fluency deficit in schizophrenia spectrum disorders, and that this action fluency deficit is linked to the language functioning, cognition, and interpersonal communication of patients with schizophrenia spectrum disorders. Indeed, when we go to these hypotheses about endophenotypes, we understand that schizophrenia is characterized by the variability of clinical phenotypes and related extensive genetic heterogeneity. And as Professor Assoc says, despite more than a century of research, the multifactorial causes and biological underpinnings of schizophrenia and related disorder are still poorly understood, and we should find different ways, different approach how to study, how to discover, explore which parts of brain are responsible for those devastating conditions like cognitive dysfunction and cognitive deficit and negative symptoms in schizophrenia. And there could be genetic research, and it also might be linguistic, psycholinguistic research, because it really can shed the light on the origins of the schizophrenia symptomatology. And here I show the famous study supervised by Professor Brad Clements from the University of Georgia, United States. It's the direction of endophenotype research, which is still very popular and supported by many research groups around the world. This study was granted by the National Institute of Health, and it demonstrated that the multiple biological pathways lead to similar symptoms, and that these biological underpinnings and these biotypes can predict the disorder course and outcome. And inside these cognitive endophenotypes, we would like to say that there is one of the key roles of language and thought, language, and communication dysfunction. So here at the slide, you can see one of the study groups who follow this endophenotype research direction in Western Australia. This is the study group supervised by Professor Assoc Jablensky. Professor Assoc Jablensky is one of the leading experts in the field of schizophrenia research, and I am lucky, happy, and sincerely deeply grateful for our research collaboration and mentorship, incredible mentorship from Professor Assoc Jablensky. Professor Assoc Jablensky has organized this Center for Clinical Research in Neuropsychiatry in the University of Western Australia in 1995. And one of the direction of research is endophenotype research, as I already said, and endophenotypic markers related to diagnostic and prognostic subtypes of schizophrenia. That's what the study group of Professor Assoc Jablensky is searching across the projects. And one of the impressive long-term huge project has been initiated in this Center for Clinical Research in Neuropsychiatry in 1996 and exists for more than 25 years. And the aim of the project was the deconstructing of the heterogeneity of schizophrenia as the unitary disease and subtyping the clinical phenotype on the basis of its underlying neurocognitive endophenotypes. Indeed, while the phenomenological core of schizophrenia is a profound annihilation of the sense of self, the primary mental breakdown, which is manifested in thought and language abnormalities, and impaired social communication, but still delusions and hallucinations as positive symptoms of the disorder. The group of Professor Assoc Jablensky and me, myself, we subscribe to the view that schizophrenia is first and foremost a cognitive illness, while psychosis is a secondary and associated part of it. So thought, language, and communication abnormalities are the key core issues of schizophrenia. And not only diagnosis should be based on detailed, precise studies of these complicated phenomena of thought and language disturbances, but also the treatment approach should target these complicated disturbances. What endophenotypes actually are? These are subsets of biomarkers representing measurable components unseen by the unaided eye along the pathway between disease and distal genotype. And indeed, endophenotypes are associated with illness, but not part of its diagnosis. Sometimes they're heritable, they occupy with the terrain between disease symptoms and risk genotypes. They are state independent, co-segregating with the illness and families, and found in unaffected relatives at a higher rate than in the general population. And the research of the team of Professor Assoc Jablensky demonstrated and discovered the two pure types, phenotypes of schizophrenia. One is a cognitive deficient subtype, and the second, cognitively spared subtype. And what is important that these two subtypes are differ on the variables related to language, such as verbal learning and verbal fluency. Professor Jablensky says and emphasizes why we should focus on the language studies in schizophrenia, because still clinical interview and diagnosis of schizophrenia remains primarily based on the symptoms or self-reported subjective experiences, and there are just few objective signs, while they are also presented through thought and language disorder. And as Blair said, primary symptoms of schizophrenia find their expression in language, but here the abnormality lies not in language itself, but in the way it has to say. So it's very important to understand the relationships of between language and other case symptoms, such as thought disturbances and communication abnormalities. And really still language and speech are the primary source of data for psychiatrists, either to diagnose or to treat mental disorders. The recent research of the linguistics of schizophrenia showed that language-related neural circuits or networks underlie the main clinical states and symptoms of schizophrenia. This linguistic group from United Kingdom and Spain demonstrated that linguistic disorganization in the schizophrenic brain plays a more central role in the pathogenesis of the disease than commonly supposed. And against the standard view that schizophrenia is a disturbance of thought or selfhood, of the self-disorder, which we discussed in the beginning of the lecture, we argue that the origins of the relevant forms of thought and selfhood at least partially depend on language. And within this model, the three main positive symptoms of schizophrenia, as Professor Rozelle and Professor Hinz state, fall into place as failures in language-mediated forms of meaning, manifesting either a disorder of speech perception, auditory verbal hallucinations, or abnormal speech production, running without feedback control, such as formal thought disorder or production of abnormal linguistic content, the disorder of content, delusions. We are still at the same position with the Kraepelin's views on language phenomena in schizophrenia, and who discovered language phenomena as one of the key features of schizophrenia. Kraepelin wrote about the derailment in the train of thoughts, derailments in the expression of thoughts and speech, disorders in connected speech and confused syntax, derailments in linguistic expression form, especially important domain in speech disorders of dementia praecox, and influence in a morbid way the form of speech. So Kraepelin many times emphasized the role of language in the pathogenesis of schizophrenia. What are other observation theories and hypotheses related to the language in schizophrenia? Already Kleist discovered that there are multiple discrete types of schizophrenia, and he described thought disorder as dysphasia, where comprehension is unaffected, and speech expression is similar to frontal motor aphasia, Broca's aphasia, which we discussed today, and paraphasias are similar to the temporal lobe aphasia, Wernicke's word amnesia. It's very important. So language disturbances in schizophrenia remind different types of aphasia, like they happen across brain lesions. Cameron wrote about the asyndactic thinking with over-inclusiveness or metonymic distortions or word approximations, which the patients use in their speech. Ellen Chaika, the linguist, wrote an impressive paper which is cited and cited over and over again. She said that language and thought disturbances in schizophrenia is some sort of intermittent aphasia. Tovey also described the dissemantic hypothesis, and he emphasized the existence of so-called phenomena of semantic hyperpriming when the retrieval is increased and intrusion of inappropriate normal associations is presented in patient's speech. Peter McKinney and Thomasin also describe formal thought disorder as primarily a disorder of pragmatics, so as the failure to use context meaning and the failure to take account of the needs of the listener or interlocutor. So the key disorder of schizophrenia, the formal thought disorder, is also related to the language processes such as pragmatics. It's very, there is also a famous review published in Schizophrenia Bulletin by Lynn DeLisi, and I can not mention this important paper. And she described the summary of the main linguistic findings in schizophrenia and demonstrated that almost all the levels of language and speech organization are disturbed. Speech comprehension, attention and interference, which affect this attention deficit, selective attention deficit that affects speech, organizations, semantics, fluency, complexity, reference failures, grammar, language literalization. So many levels and many indicators we can find as disturbed when we study schizophrenia language. Nancy Andreasen, the professor of psychology from the University of Iowa, was the first one who reviewed those language disturbances in schizophrenia in details and suggested to use, to our opinion, rather reasonable terms such as thought, language, and communication disorder for schizophrenia key disturbances. And while we decide what comes first, either to start or it's language, but we can understand that there is just some kind of measure of their interrelationships which are expressed in the process of communication or social interactions. And you can see here those phenomena which Nancy Andreasen described: phenomena of poverty of speech, poverty of thought or laconic speech, phenomena of poverty of content of speech, those negative symptoms of speech and language disturbances, poverty of thought, empty speech, allogy and verbigeration, the pressure of speech, destructible speech, tangentiality, derailment, loss of association, and flight of ideas, incoherence, which we also discussed already today before, illogicality, clanging, neologisms, word approximations, paraphrases, circumstantiality, loss of goal, perseveration, echolalia, blocking, thought blocking, stilted speech, and self-reference. However, the further research shows that not all the language disturbances or phenomena described by Nancy Andreasen have been associated with schizophrenia. Many of these symptoms have been also related to bipolar disorder and other psychoses. So the most pathognomonic, I would say, symptoms of language disturbances are the poverty of speech and tangentiality, derailment, and incoherence. So you can see that language criteria has been implemented into schizophrenia diagnostic criteria into DSM since its third edition, and ICD classification, and we can see that such symptoms as disorganized speech, frequent derailment, or previously topic shifting, and incoherence have been described as basic criteria, and also such negative symptoms of restrictions in fluency as blocking and productivity of speech, such as allergia, or previously poverty of speech, have been described as the basic criteria of schizophrenia. In DSM-5, we already could see the frequent derailment or incoherence under the criteria of disorganized speech, and more extensive representation of language disturbances as the criteria of schizophrenia in the ICD classification. You can see at this slide. As we now follow to the ICD-11, we can see that also speech disturbances or language disturbances are presented among core symptoms of schizophrenia among diagnostic criteria, and such symptom as paucity of speech or thought blocking as the expression of paucity of speech are presented among the symptoms, diagnostic criteria of schizophrenia. So there were many research, many projects, many studies done on the topic, and you can see here the Thought and Language Index as organized by the Lidl. And these components of the Thought Language Index include impoverishment, poverty of speech and weakening of goal, disorganization, domain, looseness or derailment, tangentiality, peculiar words, peculiar sentence, peculiar logic, and dysregulation. Dysregulation domain, which includes perseveration, repetition of ideas, and destructibility by external stimuli. And another scale, which is titled CLANG, Clinical Language, discovered three major kinds of language dysfunction and schizophrenia, and they are presented at the slide. It is, first of all, syntactic dysfunction, and it affects the structure of language at all the levels, including lexical access difficulties, inability to remember the appropriate word or phrase, or formulate the idea. A semantic dysfunction, which affects the ability to map thoughts onto language and pursue a communicative goal, to continue communication, and it corresponds closely to the traditional definition of thought or formal thought disorder. And production dysfunction, which comprises poverty of speech, lack of details, and lack of intonation. It is associated with the negative symptoms of schizophrenia. And of course, I would like you to pay attention at this paper, which is very important. The paper published by Timothy Crow at the British Journal of Psychiatry. The paper, which is titled Psychosis and the Price, Homo sapiens Space for Language. And Professor Timothy Crow from the University of Oxford was the one who followed, one of those who followed the evolutionary concept and emphasized the hereditary nature of schizophrenia and the role of language in the formation of positive symptoms of the disorder. Language abnormalities in schizophrenia are genetically determined, so it has been proved across many studies, and we should understand that language integrates multiple levels of linguistic and cognitive processing, as language is a dynamic system, and it can develop itself. And abnormalities of speech in schizophrenia are associated with thought and communication disorder. And Peter McKenna even said that patients are characterized by so-called thought-disordered schizophrenic speech. And what is important that language abnormalities in schizophrenia are genetically determined, that it is found by overpresentation of deviant use of language, semantic impairment, and communication anomalies in clinically unaffected relatives. So again, we're talking about these cognitive endophenotypes and representation of language and thought disturbances in unaffected relatives and families of schizophrenia. And another research projects I would like to mention here. It shows that the automated language or manual language analysis can predict the onset of psychosis, and that linguistic indicators measures can play the diagnostic role and demonstrate their predictive value for the course of the disorder prediction. Another important issue is it is well known that schizophrenia is characterized by disintegration of mental processes, and according to this disintegration theory of schizophrenia, language, in particular semantic dysfunction, is considered to be a failure to integrate sensory motor interactions, perceptual synthesis, and cognition. And specifically, it is related to the consolidation of associated synaptic plasticity in those zones of emotional learning and memory. So when we're talking about language disturbances, we're also talking about thought disorders, so talking about communication disturbances, we also talking about sensory motor interaction disturbances and problems with perceptual synthesis and memory processes as well. So reduced capacity of integrating the various elements of perception into coherent representation of object is also presented in schizophrenia, and there is really, as Paul Lysaker says, a derailment of internal and external dialogue, which leads to the impairments and associative processes and affect dysregulation. So affect dysregulation follow the primary disturbances in thought and language. So the most prominent and leading and primary impairments in semantic and pragmatics have been confirmed as associated with the schizophrenia. So the key features of the verbalizations in schizophrenia, deviant language use is anomalous semantics. And we can see again many studies who found the impaired semantic fluency in schizophrenia, the abnormal semantic activation, hyper and hyper priming, and impaired use of context, difficulty noticing semantic violation in sentences, excessive semantic activation during the initial stage of word processing and semantic errors, and problematic comprehending figurative language construct like idioms and metaphors, which is well known as associated with schizophrenia. But when we're talking about the leading impairments in semantic and pragmatic associated with schizophrenia, it's very important also to address you to the aspects of normal conversational speech, what these characteristics are. First of all, it's spontaneity. So utterances occur spontaneously, not only as a response of questions. Normal speech is also fluent. So non-fluent speech is halting and laborious and often with poor articulation. Conversational speech is also tone-taking, and the speaker and listener take turns, so it's not monopolizing of the conversation. It's also a mutual topic, so staying on the topic or focus, not straying or perseveration. It's also comprehension, so each participant understands the utterances of the other. It's also making sense, so speech that is not understandable despite adequate articulation indicates cognitive problem in a patient. And associated behavior, facial expressions, gestures, body language convey conversational information, so they are all congruent to verbal information. And language in schizophrenia and is impaired, and impaired language production at macro level of executive functions and pragmatics are registered in schizophrenia. And moreover, the research on poor fluency, less informativeness of speech, poverty of speech, an ability to use pragmatic rules to build up the context of communication. So also deficits in action planning, ordering and sequencing, damaged action fluency in schizophrenia, and poor verbal fluency based on the reduction in semantic memory store are found. And patients following these impaired language and thought disorder, they find it difficult to formulate what they want to communicate, to retrieve information from declarative memory, to generate an appropriate mental model to express information about their goals. And moreover, it's all associated with the inferior frontal and temporal activity, as the review of Cooper-Berg demonstrated. So you can see that many studies demonstrated the verbal fluency deficit in relation to schizophrenia spectrum disorders, and we consider that verbal, semantic, and in particular action fluency decline as an endophenotypic marker of schizophrenia. Decline in verbal fluency is actually not an easy and not a superficial phenomenon, and it's a characteristic finding in schizophrenia involving a combination of mechanisms and processes underlying these phenomena, such as semantic processing skills, decline, difficulties using context, and executive dysfunction. Actually, semantic fluency deficit has previously been proposed as a potential endophenotypic marker in schizophrenia and was reported to be more impaired than phonetic fluency, and also observed in unaffected relatives, what is important for our hypothesis. But the majority of previous studies have focused on object words, nouns, rather than action words, the verbs. So the primary research supervised by Professor Jablinski and led by Professor Joanna Bedcock demonstrated the relationships between action, verb, fluency deficit in schizophrenia and such clinical symptoms as odd speech, constricted affect, and increased social anxiety, but not to positive symptoms of hallucinations and delusions. Indeed, the action verb fluency tasks is an easily administered instrument, and it has been developed to measure the verb retrieval ability by Piat in 1989. And this task draws on evidence of a dissociation of the neural systems, neural networks, supporting the generation of verbs versus the generation of nouns. And indeed, many interesting research projects demonstrated that, for example, patients with a frontal lobe injury showed verb retrieval difficulties, but retrieved nouns at normal levels. In contrast, patients with more posterior lesions in the brain demonstrated relatively intact verb production, but poor noun generation. Another study demonstrated that common and proper nouns are primarily represented in posterior and anterior temporal regions, respectively, whereas retrieval of the verbs relies on the integrity of frontal neural circuits. So they are close to the Broca's area and they're close to motor zones in frontal cortex. And we again remember these data on neurobiology of schizophrenia and those zones in the left brain which are predominantly damaged in schizophrenia patients. Another interesting study showed that patients with diagrammatic aphasia, so with this frontal lobe compromise, show deficits in verb retrieval despite preserved noun retrieval. And in contrast, patients with anomic aphasia, temporal lobe dysfunction, they demonstrate greater difficulty with noun retrieval rather than verb retrieval. It is also important, actually, to pay attention at action words meaning. And it is interesting that action words meaning and movements, they share the same neurobiological underpinnings in motor and premotor cortex. Event-related fMRI studies show that action verbs referring to face, arm, or leg actions, for example, to lick, to pick, or to kick, when presented in a passive reading task, differentially activated areas along the motor strip that either were directly adjacent to or overlapped with areas activated by actual movement of the tongue, fingers, or feet. And these results demonstrated the referential meaning of action words, so the verbs, has a correlate in the somatotopic activation of motor and premotor cortex. This is called a unified meaning center in the human brain. And here at this picture, you can see the results of this study and the illustration of this somatotopic organization of the motor cortex and how the words related to tongue, arm, and the feet movements related to the activation in the same zones as actual actions and actual movements. And you can see again this similarity in hemodynamic activation during tongue, finger, and foot movements. These are localizer scans presented, and hemodynamic activation during reading action words related to face in green color. You can see here related to arm in red color. You can see this similarity, and the leg blue movements. Here they are. And there is also an overlap of activation produced by arm and leg words with it produced by finger and foot movements respectively. You can see this overlap and these scans too. Besides frontal regions, occipital-temporal cortex again also play a role in action understanding and action response. Brain connection, so words, perception, and action has been also demonstrated by the very productive group of supervised by Professor Miller. And these studies show that the things are much more complicated than we can imagine, and that there are cortical connections between areas responsible for words, for perceptions and actions involving visual, auditory, and motor and articulatory areas in the brain. And it also addresses back to this simple scheme of interrelationships between Broca's area, Wernicke's area, motor cortex, and again, we discover more and more details on how these all connected. Very interesting paper published in Nature in 2016. It represents the semantic atlas of the cerebral cortex. And this semantic atlas suggests that topographical differences in brain activation are driven by word meaning. So action versus object semantics are rather than grammatical class per se, verbs versus nouns. So it's important not to measure only characteristics of verbs versus nouns, the amount produced across the fluency task, but it also important to go further to the meaning of each concrete word produced. So we also relied on another study by the group of Miller, which demonstrated that there is a difference between abstract and concrete verbs production, and between high motion and low motion verbs production in people. And this also gave us idea, and gave idea to my supervisor, Professor Joanna Bedcock, on how to go further into our action of fluency research. Indeed, the neural and anatomical systems involved in processing concrete action verbs, such as to run, to poke, versus abstract mental states, e.g., to think, to desire, still matter of considerable debate in professional community. But it's quite obvious that processing action and mental state verbs involve dissociable cortical networks that are flexibly engaged in representing the sensory, the motor, and the affective features of actions, and also the abstract motives driving those actions. Besides semantics, beside the meaning of word and the verb, lexical characteristic also influence the verb's performance or verb's production by people. For example, such psycholinguistic characteristic as word length is calculated as the length of words measured in the number of letters. And it's already, it was found that the shorter words are easier to produce than longer words. Also, it is very important psycholinguistic characteristic which also affect verbs performance. It is called word frequency. It is the number of occurrence of a word in the psycholinguistic corpus, and we use the psycholinguistic corpus by Prism. And it is well known about these characteristics that healthy people, high frequency verbs are recognized and produced faster and more accurately without the errors than the lower frequency verbs. And both schizophrenia patients and healthy controls produce a greater number of higher frequency words when performing semantic non-fluency task, not a semantic actual fluency task. It hasn't been yet studied. And another psycholinguistic characteristic which is important for the verbs production analysis is the valence. Valence is the characteristic which describe the emotional property of verbs, which reflect the pleasantness of the stimulus estimated with the corpus of English lemmas by Warner. And we can find the verbs by the characteristic of valence and measure them when one is related to happy, feeling of happiness, excited, and controlled, and 9 is the number which is related to the unhappy state or being in control and being calm, so not excited, not emotional. And it's known regarding the valence that a faster response to words with positive meaning usually happens. Another psycholinguistic characteristic, which is called age of acquisition, it is the age in years when the verb was acquired based on the rating of 30,000 English words by Cooperman. And it's known that in healthy individuals, early acquired words tend to be retrieved faster than late acquired words, for example, in the same fluency task. And it is called an age of acquisition effect. Patients with schizophrenia generate words with a lower average age of acquisition through similar frequency and word length on a semantic animal fluency task as compared to controls. As related to action verbs, such as those associated with the leg, to kick, to walk, and mouth, to bite, to lick, are typically acquired earlier than mental state verbs denoting states of cognition, for example, to think, to pretend, or emotional states as to like, to love in normal participants, but haven't studied in schizophrenia. And it is also known that early learned action verbs have a systematic and meaningful link to body parts and to perceptual experience, hence are tightly coupled to motor actions and more certain meanings acquired through action experience or actions observation or observation of the actions done by others, while mental state verbs related to cognition and emotion are acquired through verbal linguistic interactions. Another lexical characteristic, concreteness, is also very important and affect the word's production. The concreteness is the degree to which the concept denoted by a word refers to a perceptible entity, so something which can be experienced directly through senses or action or observable behavior. And the concreteness can be derived from the psycholinguistic corpus of more than 40,000 English lemma by Prism. And there are these scores when one is related to more abstract meaning and 5 is related to more concrete meaning. So the higher number, the higher the concreteness of this lemma. And it is studied, and it was shown in the research that the concrete words are easier to remember than the abstract words because they activate specific perceptual memory codes in addition to verbal codes. And in healthy controls, concrete words are easier to process because of their imagistic representation and strong affiliation to memory context. However, patients with schizophrenia fail to recruit the dorsolateral prefrontal cortex in response to concrete relative to abstract sentences, as Cooperberg reported. Action verb fluency is also correlated with general cognitive abilities. Intelligence and education are positively correlated with the verb production, whilst verbal fluency appears to decrease with age or increase with age. Some studies are controversial. Action fluency is associated with the measures of working and semantic memory, response inhibition, and cognitive flexibility processes. Executive dysfunction plays a role in action fluency performance as well. Also, undermentalizing or deficient theory of mind, which refers to reduced ability to understand the beliefs, intentions, and mental states of others, has been linked to the prominence of the negative symptoms. And hypermentalizing or enhanced theory of minds involving excessive attribution of beliefs or intentions to others has been more strongly associated with positive psychotic symptoms such as delusions, for example. So our study hypothesis in the research were the following. We thought that the patients with schizophrenia spectrum disorders will produce fewer correct words than healthy controls on the action fluency test, in keeping with previous findings. Patients will generate both fewer action verbs and fewer mental state verbs compared to healthy controls, with a larger effect size for mental state verbs due to their greater cognitive demands. And the third hypothesis that the age of acquisition of the verbs produced will be lower in schizophrenia than in healthy controls, so the average verb frequency and length may not differ. We studied 46 schizophrenia patients with schizophrenia spectrum disorders. They were inpatient and community-based. They were from inpatient and community-based mental health services in Perth, from Perth, Western Australia. They were in the stable condition, clinical condition for at least 1 month. And as for antipsychotic medication, 7 of them were on typical antipsychotics, 13 on atypical antipsychotics, and 26 patients were on the received combination antipsychotic therapy with antipsychotic agents for the management of the side effects. There were 36 patients of schizophrenia among those of schizophrenia spectrum disorders group. For healthy controls, we used the data from healthy community volunteers with no self-reported or family history of psychosis. And of course, we excluded patients with a history of neurological disorders, organic disorders, or head injury, or with concomitant loss of consciousness for more than 10 minutes across the lifespan, and concurrent substance abuse or dependence. We also excluded these patients, and also patients with a poor fluency in English. They have been also excluded from the study group. As for clinical evaluation, we use the diagnostic interview for psychosis to analyze social and clinical indicators of the mental state. Also, we used brief psychosis screen for healthy participants to exclude psychosis and to prove the data from self-reports regarding the psychotic experience. We also used the 74-item schizotypal personality questionnaire. And as for cognitive measures, we used the list of the National Adult Reading Test for measurement of primary beta intellectual functioning, the Shipley Institute of Living Scale for measuring current intellectual abilities, the continuous performance test for measuring attention, rare auditory verbal learning tests for measuring immediate and delayed verbal memory, the Helling sentence completion tests for measuring executive control function, and the process of the response inhibition, and the tapping task for motor functioning, as well as the Edinburgh handedness inventory for measuring the laterality phenomenon. So what is the action fluency task? I would like to show you. This is the standard tests and standard instructions of the following. I would like to tell you to tell me as many different things as you can think of that people do. I do not want you to use the same word with different endings like eat, eat, and eating. Also, just give me single words such as eat or run rather than a sentence. Can you give me one example of something that people do? And after the patient give you the example and you understand that he or she understands the task, you can proceed with the action verb fluency assessment. And a patient should name the verbs during 60 seconds and you measure 4 time periods of 15 seconds each. Unacceptable answers were corrected by the researcher and followed by a prompt to provide another example of things that people do if patients were wrong, and the restart of the test. And performance was scored by summing the correct word responses, the number of repeated words, so repetitions, and the number of intrusions, so non-verb responses. And here you can see the difference between schizophrenia and healthy control, and it's indicative. You can see that there is an action fluency deficit in schizophrenia patient as compared to controls. And what's about the methods of semantic analysis of the verbs, because we needed to discover the verb meaning and to understand what's happening with the neural processes underlying the verb production in schizophrenia. We use the Levin's taxonomy of English verbs and the classes, which include more than 40 classes of verbs and their alternations. All correct and repeated verb responses, more than 2,000 verbs were evaluated according to their relevant semantic properties and meanings according to classification. And we split the verbs into 2 superordinate semantic categories. First, the action verbs, which refer to concrete observable actions, often strongly related to specific body parts or regions, such as to chew, to push, to run. And the second category, mental state verbs, they are defined as verbs whose meaning relate to understanding, discovering, planning, and or deciding, such as to know, to feel, or to believe. Besides category of psych verbs, according to Levin's classification, we also include verbs of perception, e.g. to see, to hear, of cognition, to think, to guess, and emotion, to love, to adore. And we also relied and recheck the categorization of verbs according to the theory and the approach of a linguistic category model by Cohen. So we classified verbs on two categories: descriptive action verbs, which refer to specific actions, events with a clearly defined beginning and end, as Simon and Fiedler propose, such as to heed, to call, and the state verbs, e.g. mental state, referring to cognitive, for example, to decide, to understand, or affective states, to hate, to admire. And what we received, the results. Inter-rater reliability check was conducted by two independent experts in the field of linguistics to determine the consistency of semantic categorization made by our group. And for a random sample of 14 participants and for the whole sample of 122 participants, this was a high level of agreement between raters on whether verbs were categorized as action verbs or mental state verbs, and the kappa Cohen was 0.9, which is the high level of agreement. And here you see the example how we categorize the verbs according to the classes. For example, to eat, it's related to the class ingesting and subcategory eat, or to breathe is the verb which is related to the category involving the bodily process, breathe. Or for example, to work, it's related to the class of motion verbs, in particular the manner of motion, and in particular the run. Everything is presented in Beth Levin's classification, Stanford classification. And what we found that preliminary comparisons showed that healthy control were older and had completed more years of education and demonstrated higher IQ and memory and the executive function and attention test scores, but they did not differ in gender distribution compared to the schizophrenia group. The results showed medium to large effect sizes across all cognitive measures, indicating that schizophrenia patients performed worse than healthy control group. Patients also produced significantly fewer words in total on the action fluency task than healthy control, including correct word responses and the repeated answers or repetition score. And the number of intrusions produced by schizophrenia patients was significantly higher in schizophrenia patients, yes, than in healthy control. So the average of both groups was very low. A mixed design analysis of variance was conducted to compare the percentage of action verbs and mental state verbs produced between groups comparison. And we found that the main effect of verb category was significant, and on average, a higher percentage of action verbs was generated compared to percentage of mental state verbs in both the schizophrenia and healthy control groups. And as predicted, the percentage of action verbs generated was significantly lower in schizophrenia patient as compared to healthy controls. However, percentage of mental state verbs produced by schizophrenia patients and healthy control was not significantly different. And the main effect of verb category was significant. We demonstrated this. And what is also interesting that we didn't find a significant difference between schizophrenia cognitive deficient subtype and cognitively spared subtype, but we found the similar pattern of the results. Patients with schizophrenia produced fewer percentage of action verbs than healthy control, but the percentage of mental state verbs did not differ. And of course, the sample size is small and the full analysis is underpowered. However, we can obviously see the similar pattern of action, selective action verb fluency deficit related to cognitive dysfunction. What's about the lexical characteristics of action versus mental state verbs in the whole sample? Within the whole sample, compared to mental state was the action verbs generated were characterized by a shorter word length, a lower word frequency, an earlier age of acquisition, a higher concreteness ratings, but did not differ in valence. Non-parametric tests indicated that the action verbs produced by schizophrenia patients had lower concreteness ratings, so they were more abstract than those verbs, than the action verbs, those verbs produced by healthy controls. However, they didn't differ between the two groups in other lexical characteristics. So, neither age nor medication dose were significantly associated with either action verbs or mental state verbs generation. In contrast, education and general intelligence were positively correlated with action verbs generation, and action verbs fluency was significantly negatively correlated with the interpersonal domain of the schizotypal personality questionnaire, comprising the domains of social anxiety, no close friends, and constricted affect, but not with the other SPQ domains. So you also can see that action verbs fluency deficit significantly and positively correlated with the immediate and delayed recall scores on the RAL test, but not associated with the inhibitory control and attention or motor speed and laterality. Mental state verbs fluency was not significantly correlated with any of the SPQ domains, but showed a correlation with the premorbid intelligence and immediate recall on the RAL tests. So the main finding in our project is that we have the selective fewer action verbs fluency in schizophrenia. The aim of the studies, you remember, was to investigate the specific features or origin of action verb fluency impairments in schizophrenia, and we analyzed the verbs output of schizophrenia patients and healthy control using cognitive linguistic approach. We studied semantic categorization versus mental state verbs. We studied lexical characteristics, and we studied correlations between cognitive and clinical features and action verbs production. And what we found, the current results strengthen the evidence of selective difficulties in verb action semantic generation in schizophrenia patients using an action naming TAS, and the impairment in action, but not mental state verb generation in schizophrenia is consistent with the notion of separable cortical networks being activated by concepts referring to actions as compared to mental state verbs, respectively. So patients with schizophrenia produce fewer action verbs, but it was not due to the verb difficulty effect, because mental state, not action verbs, are regarded as more difficult. It was not due to age-related decline in fluency performance, because schizophrenia patients were younger than healthy controls. This finding is also not due to the low intelligence or education of schizophrenia patients, first of all, because the number of intrusions was small and didn't differ as compared to healthy controls. And it would differ. It was related to the intelligence and education of patients. And also because the schizophrenia patients produce selectively low percentage of action verbs and the same, not lower percentage of mental state verbs compared to healthy control. This finding is also not due to the poor reliability of semantic categorization, because we demonstrated that inter-rater reliability was high. And it wasn't due to the effect of medication, because this clozapine dose equivalent medication was unrelated to the fluency task. So this finding is really unique. Another finding is that action verbs produced by schizophrenia patients were characterized by the low concreteness and the same age of acquisition. Action verbs produced by schizophrenia patients were less concrete than the verbs produced by healthy control, and these created difficulty integrating verbal and perceptual semantic representation associated with the concrete meaning of action verbs in schizophrenia patients. As we see now, and it also says us about the greater difficulty with the precision of encoding or reactivating the perceptual memory codes in schizophrenia. So the sensory, motor, and affective information, the template verb meanings, they are which are associated with the root level verb meaning and conveying the uniqueness of individual verbs, they are very, they demonstrate this greater difficulty of encoding, reactivating, and production by the schizophrenia patients. And as for the age of acquisition, our findings on the same age of acquisition as compared to schizophrenia patients produced by schizophrenia patients and healthy control shows us separable influences of age of acquisition on action versus object semantics. Also, mirror neuron dysfunction and ERP event-related potential studies and motor resonance studies can explain the underlying mechanisms and should be included in future research, the dysfunctional mirror neuron system, to our point of view. And another finding in our project, in our study, that the action verb fluency deficit is related to memory and IQ rather than executive function. We found that action verbs were correlated with the memory and IQ, but not with inhibitory control and attention. And it is associated with the data that patients rely on memory of actions and experience, and it can be associated with the psychomotor poverty, which has been described in association with schizophrenia disorder. And we also are interested whether the degree of sensory motor impairment could predict the action of fluency deficit in schizophrenia patient in line with the classical theories of the embodied cognition. You can see the very interesting book by Merleau-Ponty on phenomenology, la perception, phenomenology of perception. Of course, for further research, we should try to discover the connections with the embodied cognition. What we should also focus on the relationship between action verb fluency deficit and the goal-directed actions, which are impaired in schizophrenia, and this action verb selective deficit could point to this impairment in the goal-directed actions. So it could be also the target for psychotherapeutic intervention when through training the goal directed actions, we can train the action fluency deficit and those key function associated with the action fluency deficit or fluency deficit, such as cognition and thought disorder. For further studies, we also may measure motor deficits in association with the action fluency deficit and in relation to both patients and the risk cohorts at risk. And another finding is related to the action fluency deficit and high interpersonal SPQ scores. Conversely, action but not mental state verb fluency was negatively correlated with the interpersonal schizotypy traits such as increased social anxiety, no close friends, and constricted affect. And this increased sense of psychological distinct from others may be related to the less concrete words which are associated with a sense of psychological, emotional, or physical distance. So we can think about this as well, that action fluency deficit point to communication problems, to poor, and the indicator of poor interpersonal functioning. The Burns psychopathology scale, which measures language, affective, and motor domains, could be also used to prove our hypothesis. And to conclude about the study, we should say that the impaired action verb but intact mental state verb generation in patients with schizophrenia is consistent with the neural separability of these processes, different neural networks which are responsible for these processes. So it is the finding about the disintegrated semantics in schizophrenia again. And also this finding, the main finding, points to a specific relationship between the action-related language, we dare to say action verbs, and memory deficits and poor interpersonal functioning in schizophrenia spectrum disorders. And here we continue the research and using the communication checklist self-report further to find the relationships between the action-related language and performance, communication performance, and language disturbances at the levels of pragmatics and social engagement and semantics. And we already published the preliminary data which demonstrated that schizophrenia patients are aware of their language and communication disturbances at all levels, as measured by this communication checklist self-report at all the levels of language structure, pragmatics, and nonverbal communication. But patients are unable to compensate these difficulties, no matter they are aware and recognize them. And the disturbances of these social engagement and pragmatic skills, they relate to poor social adjustment and functioning and may prove to be associated with the primary negative symptoms domain of the disorder and its general poor outcome. And focusing on this finding, I would like to say a few words about the importance of cognitive interventions and action language therapy, which is used for aphasias and now can be used for schizophrenia to improve fluency in schizophrenia and related K symptoms of schizophrenia, such as cognitive disturbances, thought disorder, social adjustment, negative symptoms of social disadjustment, and so on, and functional outcome of the disorder. So we should target particular language related mechanisms which really play the central role in the pathogenesis of schizophrenia to our mind. And I hope that by this lecture we not only introduce you to the topic, but convince you to follow the same meaningful hypothesis as we suggest. And finally, the message of this talk is not only about to hear our patients, but it is also important to spread the word to our patient, to treat our patient, and also to take real action to treat schizophrenia. Don't just do it, as the famous advertisement states. And finally, I would like to say that we're happy to collaborate with you all within a project of the iCERN Web Library of Neuropsychiatry. And here is the email for your collaborative words and actions. Thank you very much for your attention. Bye.